Very happy to introduce my co-chair on the overall forum on public-private partnerships for global health and safety, Clarion Johnson. Clarion is the co-chair of the forum and has served as the global medical director of ExxonMobil Corporation until his retirement in 2013. He's currently a consultant to ExxonMobil, the chair of the Joint Commission's International and Resource Boards, and a member of the Yale School of Public Health Leadership Council. And I was telling him, for somebody who's retired, he looks like he's managing emergencies 24/7. So at any rate, I'm sure he's in high demand. We have really enjoyed working with him. I have especially. And Clarion, over to you to set up the next panel and manage it for us.
Thank you, thank you. Welcome back. Hope you've enjoyed lunch. We've tried to do the healthy thing for you. And so that means you can eat more. Again, this afternoon I have what I believe is a truly impactful panel. Two of the three are from across the pond, so we have truly an international group. The good news that I want to make you very quickly aware of is that they don't wear just one hat. They delve into the academic, the NGO, whether it's women's issues or girls' issues, and they truly understand corporate. I would ask you, as you listen to them talk, think of what they're saying to get the things that they want to get done internally. What they're able to do, again, which is impactful, is only because they're able to get the buy-in of management. So if you can, envision them as they bring up topics and they discuss what they do, each one of them, try to see if you can see how they're presenting it to management. What sort of, and our word for the day, participants, is metrics. What sort of metrics they're using in corporate language to speak to all of you. So with that, and our models for engagement in substantial development goals, I'd like to begin with the first of three. Gary Cohen of Becton, Dickinson and Company, done a lot, does a lot. I'm still not sure how he manages to have a day job with all the things he does outside. But again, we had him come last year, really insightful. You'll see from his presentation, well thought out. And so without further ado, Gary, you're on, my man.
Thank you. Well, good afternoon, everyone. It's always a pleasure to be among friends. I'm the frog from this side of the pond among the three speakers. And I'm going to jump right into it because I typically try to pack a lot of information into a fairly tight time frame, but I was asked to speak about the different methods of social impact companies can have, and I'm going to share that, some definition of those methods, and then specific examples. If you don't know BD, we're not a household name, but in these circles we tend to be reasonably well known. It's another old company, 120 years old, fairly large, about 45,000 people in 150 countries. We've only had 7 leaders in 120 years, which itself is a remarkable statistic. And we don't actually seek a lot of recognition for the things we do, but we end up getting some nice recognition, including being included in the Fortune 50 companies changing the world list that was issued for the first time last year. So jumping into different methods of positive societal impact, I think everyone understands philanthropy. You're giving away money, you're giving away goods in kind, it's called donations, and I'm providing examples that I'll highlight here and then go into more detail on. So an example here would be donating vaccines or vaccination devices to immunize children. CSR is a term that became popularized in the middle of the prior decade. Our definition of it is deploying resources and competencies from a company to achieve positive societal impact that's not directly related to commercial outcomes. So we've done a lot of training of laboratory workers. I'll speak briefly about that. Renuka actually leads that work for the company, and that would be an example of CSR. Advocacy and policy alignment is probably not spoken about as much, but those of us who have a lot of experience in global public health, those who are trained for that experience, or the people who are less qualified, such as myself, know that you can only get so far without getting alignment of guidelines, policies, regulations, and laws. And therefore, at a certain point, it makes a lot of sense for the private sector, for companies to get involved in that, but doing so working in the public interest, not in their self-interest, which is what a lot of policy activities in companies do. So we've had experience in many areas, and the largest of which is policy changes to address risk to health workers and also to patients. And lastly, shared value creation, which is the newest of these terms, popularized in this case by Michael Porter, which is a commercial strategy for positive societal impact. You use commercial business models in a manner that delivers societal outcomes that are favorable, but also favorable business outcomes. And you'll see an example, or two examples I'll use in the area of maternal and newborn mortality. So those are some of the definitions. What makes shared value different from traditional business? We've struggled a little bit with this internally because everything BD does is healthcare related. We don't have this dilemma of having some things that may be good for society, some things that may be bad for society, which is a nice position to be in, but it causes this question of what, how do you distinguish between something that's truly shared value versus a traditional business initiative around a medical technology? And we apply a very strict definition. I'll even say it's far stricter than Porter or FSG's definition. First, the shared value initiative has to start out from the outset. The basis was to address unmet societal needs. It's not a sort of an afterthought or a byproduct. It's why you started the initiative. Second, is the focus needs to be on major societal needs that are not just assessed as such by us, but by leading authorities, including governments and international or public sector agencies. And we haven't yet seen a circumstance where you can accomplish this outside of collaboration across sectors. These problems that you're working on are so substantial that no one sector can accomplish it on its own. That's the definition we provide. And this I'm just going to do is sort of a gestalt. I'm not going to go through this in detail, although everything that's in orange highlighted are things I will talk about. But here's a series of 20 public-private partnerships the company's been engaged in since the early 2000s, I think all of which, or the vast majority of which, are still active, that fall into those various categories: shared value creation, CSR, philanthropy, and advocacy and policy alignment. But lastly, let me say, and you'll see this bear out in the rest of the material, that these different approaches can also work in unison to have even broader impact. So like every other good presenter today, I have a picture of the SDGs as well as the MDGs, because I'm going to talk both retrospectively and prospectively. And that's really just here because I'm going to now show you how each of the things I'm going to speak about align to particular MDGs or SDGs. So starting with healthcare worker safety from a shared value perspective, this one contributed to MDG outcomes by protecting health workers, which are the fundamental foundation of any health workforce. BD is the world's largest producer of needles. I think we have been since the beginning of production of needles. And by the late 1980s, there was concern about disease transmission from patient to health worker associated with accidental injuries. There was not a lot of concern among our customers at the time, but we were very concerned because we were the largest producer of needles and we felt this was an important issue. I'm going to make a very long story very short. We mobilized across the company, invested over $1 billion in not only redesigning but recapitalizing our entire needle production business across multiple business units and product areas. We worked with policymakers. But prior to that, we worked with leading activists, including those that were critical of industry at the outset, developed surveillance and training programs, and over the course of the first decade, made a lot of progress, but then really got involved more in the policy activities, which I'll talk about on the next slide. And a lot of changes occurred. We have data that shows substantial reduction in injuries among health workers, and this became the largest single source of growth for the company over the last 25 years. So this is truly shared value. In fact, according to what FSG has told us, if you're familiar with FSG, this is the largest impact they've seen of any company having from a shared value initiative. We built about $2.5 billion in sales in safety engineered devices while we were protecting healthcare workers around the world. And the policy activities were pretty far-reaching, starting in the U.S. when the first national law was passed, and I was in the White House Oval Office when President Clinton signed the Safety Act into law in November 2000. Then 10 years later, the European Union passed a European Union-wide guideline, very similar to the U.S. safety law. The last picture was actually taken in Russia when we were meeting with the Ministry of Health, and they were putting healthcare worker safety into their healthcare reform changes in Russia, and this also has happened in a number of other countries around the world. Still a ways to go, though, and I mentioned that we were collaborating with professional societies and researchers. Some of them were shown on the left of the slide, and then more recently, just early in 2015, WHO issued new guidelines on injection safety, which include healthcare worker safety, and we were very involved in that policy effort. In fact, if you look very closely You'll see Renuka standing in the front of the room of that picture taken at WHO headquarters in Geneva. So that's healthcare worker safety. I talked about shared value and advocacy and policy. Let me shift to safe childhood immunization. Around the same time frame, late 80s, the concern about disease spread among children in mass immunization programs started to really come to the surface because of reuse of single-use immunization devices. WHO and UNICEF reached out to industry for technical solutions. BD responded with the first auto-disable immunization syringe, which was co-developed or co-designed with PATH. It went into WHO field trials in '88, commercially available in '91. It took almost a decade for it to go into broad use, and there was a lot of learning along the way about the need for collaboration. Some of the things that ultimately influenced it going into widespread use were a joint policy statement, again, policy changes that came out from the leading agencies. We had to fundamentally redesign the device and move its manufacturing to a new location to get its cost down low enough, essentially to the cost of a standard injection device. And of course, Gavi came in with a massive amounts of funding and activity on global immunization. In parallel, we had partnered on disease elimination. I'll get to that in a moment. And the positive side of the story is, although it took about 8 years to go into real use, between 1999 and 2015, essentially the MDG period, over 6.5 billion of these devices were supplied by BD. And among our work and other companies' work and the partnerships, essentially eliminated this entire category of disease spread among children. And you'll hear about last mile reach. If you look at that picture in the lower right corner, that's these devices being delivered to a very remote area of Pakistan by donkey. And this is a place only reachable that way. Last mile reach in and of itself is a major supply chain challenge that in our experience needs to be also addressed through collaboration. If you haven't noticed it, also at the top you'll see the MDG and the SDG that each of these activities relate to. On the advocacy, let me see, did I pass a slide? Nope, I didn't. On the advocacy and policy side, Renuka and I both were personally involved in advocating for changes in immunization policy in India in the early 2000s, working through the Indian Academy of Pediatrics and UNICEF. At the time, India was still using reusable glass syringes to immunize children, and they leapfrogged over to auto-disabled devices in part as a result of this advocacy work. And then major philanthropy efforts as well. We entered into a partnership with UNICEF in 1998 to eliminate maternal and neonatal tetanus. Our colleague from Procter & Gamble mentioned this initiative before. It was actually started by BD bringing this idea to UNICEF. And many other partners came in, P&G being one of the largest ones, Kiwanis being one of the more recent ones. Tetanus deaths are down now by over 70%. And it's working towards full elimination. In fact, the 40th of the 59 countries that were targeted for elimination was just reached this week. I may be revealing new information that hasn't been publicly disclosed yet, but Niger just eliminated MNT, and also entire Southeast Asia has eliminated MNT. And we worked in a similar fashion with American Red Cross on measles, and we recently made a major commitment to the final eradication of polio. So here's an example of working across shared value creation, policy, and philanthropy in a related way. It's not one and the same because philanthropy has to be completely walled off from anything commercial, but each of these is complementary towards the ultimate goal. Another area where I mentioned, lab system strengthening. On the shared value side, we started to partner on establishing the necessary diagnostic capabilities in high prevalence, low resource settings for HIV and AIDS to enable the mass rollout of antiretroviral therapy to be accompanied by the supporting necessary capacity building in laboratories. The first major agreement we struck was with the Clinton Foundation in January 2004. That was an access agreement where we lowered the price of CD4 tests by about 75%. Ultimately to 55 developing and emerging countries, but we also engaged in extensive training on the proper deployment of those tests, ultimately training over 8,000 lab technicians in 60 developing and emerging countries, which essentially established the access to this type of test very broadly. I'm going to have an interesting clip at the end of the presentation that you'll hear external feedback on what was accomplished here. That background and the fact that we had also in the same time frame established the capability to deploy volunteers from our workforce to address unmet health needs in developing countries led us to enter into a public-private partnership with PEPFAR and CDC starting in 2007 to strengthen laboratory systems more broadly. This was CSR. It was not connected to any direct commercial benefit. It's a 5-year partnership that was then renewed again after 5 years with $20 million in co-funding commitment. It's now called Labs for Life. Renuka leads this for us. We've implemented in high HIV and TB burden countries, and 4 countries in Africa as well as India. Our main contribution is our expertise. Almost every technology BD is involved with, we're the underlying inventor of those technologies, including something as simple as an evacuated blood collection tube that BD invented in 1949. The CD4 analyzer BD co-invented the first commercial flow cytometer with Stanford University in 1972. Automated liquid culture for TB was also invented by BD. So we have this storehouse of knowledge that we can deploy through our associates. And this has been extensively analyzed, in fact, recently published in a series of papers in the Journal of Infectious Diseases, the outcome of this partnership, where we can point to specific accomplishments in very important areas like higher diagnosis of patients with MDR TB, which of course is a massive threat, as well as influencing and upgrading national laboratory systems in the countries that we're working in. I'm now going to shift, and I know I'm going through this quickly, but as I said, I'm covering a lot of ground. Maternal and newborn mortality. It was referred to in one of the earlier presentations that 5.9 million under age 5 children died in 2015. It's maybe not as well known, but better known than it had been previously, what proportion of those children were newborns. In fact, 45% of those 5.9 million were newborns. It equates to 2.7 million newborns dying in childbirth, almost half of all under age 5 mortality. Progress there has lagged progress in other areas like malaria, immunization-related diseases, diarrhea, and pneumonia, because the types of interventions that are necessary are different. And in addition to the 2.7 million newborns, there were 2.6 million stillborns. So the actual number is over 5 million that are dying somehow related to the process of childbirth. Closely related to that, 300,000 women and girls died in childbirth in 2015, and over 10 million had severe complications. And I talk about this a lot, and each time I talk about it, I say the same thing. It's shameful for the world that the process of giving life should create such high risk for women and girls. And I always say girls because there are countries where more than half of the pregnancies are girls. And in some countries, it's been noted that it's more dangerous for a woman or girl to give birth than it is for a man to go to war, an absolutely unacceptable circumstance. So BD hadn't been involved in this area of childbirth, but we started to take note of this because of the outcome on the end of the MDGs. And then in January 2012, I was approached by WHO at the World Economic Forum meeting in Davos with a very interesting concept and proposition. They had been championing a new device that was invented by an automotive mechanic in Argentina who came up with the idea in a dream after seeing a YouTube video of a cork being removed from an empty wine bottle, and envisioned that this could be a new way of helping with assisted childbirth to replace forceps or vacuum assist, which present their own risks. I'm not going to go into full detail on this. I will show you both the how the device works if you watch that video, and also in parallel, this is the YouTube video that he saw and then had a dream that night that this could be a way to deliver children. The inventor's name is Jorge Odon. The device carries his name, the BD Odon device. As I mentioned, WHO approached BD on this in January 2012 in Davos. It was out of the box because we had nothing in this area or even in obstetrics at all. But our skills and our know-how on device design and development were clearly pertinent. And after quite a bit of debate within the company, the point came up before, how do you get consensus? It's a very nonlinear approach, I have to say, to getting consensus, but we did get consensus to develop this device. We're now about 2.5 years into development. It's going very well. The main stage of large-scale clinical studies will start in September. We've already had the first round of clinical studies, and it's very, very promising, this new device. And the innovation here is not just in the device, though. It's in the business model. And this session is about collaboration. This is the most collaborative activity we've been engaged in. It builds on all the other experiences we've had in public-private partnership. And in fact, shares responsibility both for achieving success but also in the funding through many different organizations, with BD taking responsibility for the design, development, and manufacturing. The Saving Lives at Birth partners were funders early on. It was awarded an SLAB award in 2011, and the Economic Development Board of Singapore is also supporting development costs. The clinical studies are being conducted and funded by and through WHO, and WHO is getting funding from USAID and the Gates Foundation for those studies. We work directly with the UN, Secretary General's Office, Every Woman, Every Child, as also represented by UN Foundation and Natalie here, as well as the PMNCH on advocacy. We're working directly with the Federation of International Gynecologists and Obstetricians, who will do the practice guidelines, training protocols, and push that through their 130 country chapters, as well as with WHO. And we're in discussions, and you'll see his asterisk there because it's not complete yet, with USAID, the Global Financing Facility, and others on ultimately providing the support to countries that they'll need to access this device, as well as discussions on last mile reach and training with JPIGO and Save the Children. This is a truly holistic collaborative approach to accomplishing something that no one of these agencies or organizations, or maybe even small handful, could possibly accomplish on its own. And to show you the level of collaboration, we even had met with Pope Francis, or as I learned to call him Papa Francesco, that's what they call him locally, a very endearing name, at the Vatican, showing the support of the Vatican for these types of initiatives. By the way, the Vatican's become very progressive on these health issues. We're also co-developing new point-of-care maternal health diagnostic tests. This is at an earlier stage, hopefully with the goal of being able to achieve much earlier diagnosis of preeclampsia and gestational diabetes, which are two leading causes of both maternal and newborn morbidity and mortalities. And we're working with the Global Health Investment Fund as a co-funder, represented by Glenn Rockman here. Again, a highly collaborative approach. Gates Foundation is behind this one as well. So I did move through things quickly. I only have two more. I have one slide and one video. So key takeaways. First, philanthropy, CSR, and shared value, they're all important methods. You'll hear some talk about shared value and say it replaces philanthropy and CSR. We don't agree with that. We think philanthropy has to be here forever. You know, taking from those who have to provide to those who have not is absolutely critical, particularly for highly vulnerable, low-resource populations that will not get access otherwise. And they can work in combination. The question had been put to me, how do you determine which to use? I think it's been fairly straightforward when you need to use a shared value approach. If you have to get something to large scale, and it involves, in our case, a product or technology, it's not going to be philanthropy or CSR. It has to be shared value. Philanthropy applies in certain circumstances, but has a limit to its scale. We give away a lot. You can't give away everything. And CSR is when we have some sort of core competency that can be deployed. So it's been pretty straightforward. And as I mentioned, the difference with shared value is there's no limit to this scale it can potentially achieve. All three methods can work in combination. I don't think there's that many organizations that think about using these three in combination, but I think that can ultimately be the most powerful. By the way, public-private partnerships, if it's not obvious to you, are an art. They're not a science. Anyone who claims that there's science behind these is spending too much time in the laboratory. There's a lot of human factors that are associated with this, and a lot of rigor and discipline, and we can get into a further discussion, time permitting, about what makes them work. But we've had really, really good success with PPPs. Among the criteria that are most important is trust. You know, without trust, I would say trust and aligned motivations. I would say those are the two most important factors, and they're interrelated. If partners come into a partnership with different motivations, it's going to break down at some point. And they need to be very straight and sincere up front about why they're doing it. If a company's doing it for reputational purposes, their vested interests will go as far as it takes for them to get the positive reputational impact. And unfortunately, the reputational impact usually comes early on when it's announced. You have to be there for the purpose that you're saying you're there for. The work I've done on Together for Girls, which I mentioned briefly earlier, is principally driven by the deep, deep dedication all the partners have to that purpose. And the SDGs, at the risk of stating the obvious, offer a great opportunity, better than ever, for companies to engage around very well-defined goals and targets that they can determine are relevant to areas that they have either technology or competency or interest in. And this is really a new door opening for us. The last thing I'm going to show you is just a quick video clip, and it's because you hear me talking about it. There's a fairly credible source who's going to show up on the next slide who will share a perspective on the impact that at least one of these partnerships has had.
Over the years, Becton Dickinson has shifted its sustainability efforts. This is really important. A lot of people are trying to do this. From sustainability, from philanthropy, to delivering shared value as part of a business strategy. This guy has understated what he did. He and a lot of other people around the world, mostly U.S. and European companies, who literally had to reimagine their whole production process so they could make an acceptable profit at drastically slashed prices. They figured out a way to make this good business, at least good enough business to justify doing it, to keep several million people alive who wouldn't be otherwise. So I thank you very much.
Okay, thank you.